Hello friends, welcome to final lecture on our series on coronary occlusion, and we were studying effects of myocardial ischemia. So we have already studied about angina pectoris. Now we will we have started myocardial infarction, and now in this lecture we will look at morphological features of myocardial infarction. So first of all, what is morphologic features? Morphologic features means features related to appearance. Morphologic is derived from word morph. Morph means shape or appearance. So these morphologic features are of two types, gross and microscopic. Gross features which can be seen by naked eye are called as gross features, and microscopic features obviously which can be seen only under microscope. So gross features can also be called as macroscopic, and second one is microscopic features. So these are two types of morphologic features, gross and microscopic. So what are the gross morphologic features of myocardial infarction? So first of all, when it is mostly single patch, myocardial infarction is one in number. Its size is 4 to 10 centimeters, and it is found mostly in left ventricle. So these are changes which you can see by naked eye, and these gross changes depend upon age of infarct. That means how old is infarction. The features depend on that. So if infarct is 6 to 12 hours old, there will not be much changes. Only that affected area will be slightly paler and drier. After 24 hours, cyanotic area is developed in infarct. Cyanotic area means like the bluish color, because cyanosis develops when oxygen supply to a part is stopped. There is cyanosis is developed. So obviously in myocardial infarction, blood supply is stopped, so oxygen supply is also stopped, so cyanosis will be developed. And after 48 to 72 hours, infarct develops a yellow border due to neutrophilic infiltration. So this neutrophil come here to absorb dead part, infarcted part, because body now doesn't need this part has become dead. So this neutrophil comes to absorb, to function as macrophage, and they give a yellow border appearance to this infarct. And after 3 to 7 days, border becomes hyperemic, while center is yellow. Hyperemic means increased blood supply, due to increased blood supply. And after 10 days, peripheral area of infarcts become reddish purple, and infarct shrinks due to resorption of necrotic muscles. So as I already said, neutrophils comes there to absorb necrotic muscles. So because they have reabsorbed the necrotic muscles, infarct is shrink. If infarct shrinks, and after 6 weeks, infarcted area is replaced by fibrous scar. This is a mechanism of healing which you will learn in another chapter. Whenever there is an injury, there are many ways of healing. So one of that is healing by fibrous scar formation. So this was gross features of myocardial infarction. Now coming to microscopic morphologic features of myocardial infarction. So these microscopic changes also depend upon age of infarct, and after if they are 6 hour old, so as already described, there is usually no detectable changes. And if the infarct is 6 to 12 hours old, there will be appearance of fluid between myocardial fibers. It is seen in under microscope. Remember this, all these features will be seen under microscope. Second is coagulative necrosis begins, neutrophilic infiltration begins. So under microscope you can see in if an infarct is 6 to 12 hours old, you can see that there will be neutrophils. And after 24 hours, coagulative necrosis which has begun is progresses, and slight neutrophilic infiltrate on margins. 48 to 72 hours old, coagulative necrosis is complete, and neutrophilic infiltrate is well developed. 3 to 7 days old, neutrophils are necrosed and gradually disappear, beginning of resorption of necroid fibers. Remember, all these features comply with or correspond to the features we have seen in gross part. Okay, so what you are seeing under microscope is another is microscopic level of what we have seen without microscope, that is with naked eye. Same thing happening under microscope also. And if infarct is 10 to 14 days old, so most of the necrosed muscles of infarct is removed, neutrophils almost disappear because their function is complete, they have absorbed infarcted muscles, so now they disappear. And 4 to 6 weeks old infarct, so there will be a contracted fibrocollagenic scar with diminished vascularity. Now coming to diagnosis of myocardial infarction, how to diagnose a patient of myocardial infarction. So this diagnosis is based on three type of features. First one is clinical features, second ECG changes, and third is serum enzyme levels. So first of all, you will evaluate patient based on clinical features, and if you suspect myocardial infarction, then you will ask for ECG changes and serum enzyme levels. So what are clinical features of myocardial infarction? These are pain. First one is pain. The pain is sudden, severe, crushing and prolonged. It is substernal or pericardial in location. We have already seen in previous lectures what is substernal or pericardial region. And the pain is unrelieved by rest or nitroglycerin. Normally angina pain is relieved by rest and nitroglycerin, but if myocardial infarction is there, it will not be relieved by rest or nitroglycerin. The pain often radiates to one or both the arms, neck and back. Second clinical feature is indigestion. So this indigestion is not real, but it is due to some symptoms which are interpreted as indigestion. What are these symptoms? They are heartburn, nausea, vomiting. So patient thinks that this is due to indigestion, but these symptoms mimic indigestion. Third one is apprehension. Apprehension means if someone feels anxiety about future, then it is called as apprehension. So due to the pain and the symptoms, the patient is very terrified and restless and apprehensive because he feels that he is going to die. So this is another clinical feature. Next one is shock. Systolic blood pressure becomes below 80 mmHg, and there will be lethargy, cold clammy limbs, peripheral cyanosis, weak pulse, tachycardia or maybe bradycardia. Next one is oliguria. Oli means less in amount, so oliguria means less amount of urine. In oliguria, urine flow is usually less than 20 ml per hour, so urine flow is reduced. There will be maybe low grade fever also, and acute pulmonary edema. In some cases there are acute pulmonary edema. So these are clinical features. Now we will look at ECG changes. ECG changes and cardiac markers. So ECG changes are second point in diagnosis of a patient of myocardial infarction. First one was clinical features, and if based on clinical features you suspect that a patient has myocardial infarction, you will immediately go for ECG. So these are ECG changes. First what changes occur, we will look side by side to have a better understanding. So in this image you can see that there are two ECG. The picture on the left side is normal ECG, and the picture on right is ECG in a patient of myocardial infarction. So you can clearly see that in myocardial infarction, ST segment is, this is ST segment, this is ST segment. So in normal ECG the level, and in myocardial infarction patient the level is increased, so this is called as ST segment elevation. This is most important ECG change in a patient of myocardial infarction. Now second one is, this is T wave inversion. Here you can see that in normal ECG T wave is pointed upward, but in a patient of myocardial infarction T wave is pointed downward. This is called as T wave inversion. This is second feature of ECG. This is second ECG feature of patient of myocardial infarction. Now third feature. Third feature is deep Q wave. So in normal patient you can see that what is the level of Q wave? It is above S level. The point which is called as S, it is above that, and in a patient of myocardial infarction it goes below the level of S point. Okay, so this is called as deep Q wave. This is third ECG feature of patient of myocardial infarction. So these are ECG changes. Now we will come to serum cardiac markers. So what is this serum cardiac markers? Like any other body part, heart muscles also contains some proteins and enzymes. So after a myocardial infarction, these proteins and enzymes are released in blood. So they normally may be present also in blood, but after myocardial infarction they are released from heart muscles, so their amount is increased in blood. So if you test blood, then you can see that their amount is increased, so you can confirm that diagnosis of myocardial infarction. So and these protein and enzymes are called as cardiac markers because they mark injury in cardiac muscles, so they are called as cardiac markers. So we will look at them one by one. They are creatine phosphokinase. First one is creatine phosphokinase. It has three forms, that is CKMM, CKBB and CKMB. CKMM is derived from skeletal muscles, CKBB is derived from brain and lungs, and CKMB is derived from cardiac muscles. So you can clearly see that if CKMM or CKBB is raised, so it doesn't matter, it doesn't show any problem in cardiac muscles because it is not released from cardiac muscles. But if CKMB is raised, you can say that there is certain injury in cardiac muscles because it is derived from cardiac muscles. So out of three forms of creatine phosphokinase, CKMM, CKBB and CKMB, only CKMB is of importance to us for a patient of myocardial infarction. Okay, so now second one is lactate dehydrogenase, or also called as LDH. It has two forms, LDH1 and LDH2. LDH1 is specific for heart muscles, while LDH2 is derived from many other organs also. What does this means? This means that LDH1 is derived only from heart muscles and LDH2 is derived from other organs also. So if you measure only amount of LDH in blood, you will not be sure that it is LDH1 or LDH2. So whether it is released from heart muscles or any other organ, so it will not be helpful in diagnosis of myocardial infarction. So what you do is you take ratio of LDH1 to LDH2. If LDH1 is more than LDH2, it will indicate myocardial infarction because LDH1 is derived only from heart muscles. So if LDH1 to LDH2 ratio is more than 1, that is when it will come more than 1, when LDH1 is greater than LDH2, then myocardial infarction will be suspected. Now third cardiac markers, that is cardiac specific troponins. They are not found in blood normally. Their level in blood increases after myocardial infarction. So if you, after blood examination you see that cardiac specific troponins, then you can say that the patient is having myocardial infarction. Next one is myoglobin. Actually myoglobin is first cardiac marker to increase after myocardial infarction, but its importance is less because it is not cardiac specific. Again we come to that point that it is not cardiac specific. That means it is not secreted exclusively by cardiac muscles, but it is secreted by other organs also. So only after seeing that myoglobin level in blood is increased, you are not sure that it is due to myocardial infarction. And also it is excreted in urine rapidly. So after 12 hours, it is very difficult to detect myoglobin in blood. Now we will look at complications of myocardial infarction. Here diagnosis of myocardial infarction is complete. So there are three features we look for. First is clinical features, then ECG changes, and then serum cardiac markers. Based on these three criteria, we can diagnose a patients of myocardial infarction. Now we will look at complications of myocardial infarction. First one is arrhythmia. It is most common complication of acute myocardial infarction. It is abnormality in normal heart rhythm. What is heart rhythm? It is the normal rate and normal pattern of heart beating. So if heart beats faster or slower or irregular, that is the time duration between two beats is increased sometime and decreases sometime, it is called as abnormal heart rhythm, and it is called as arrhythmia. So it is most common complication of acute myocardial infarction. Second one is congestive heart failure or CHF. In CHF, heart is unable to pump enough blood to meet body's demand. Third one is cardiogenic shock. It is in cardiogenic shock also, heart is unable to pump enough blood to meet body's demand, but it occurs suddenly, and congestive heart failure occurs gradually. Next one is mural thrombosis and thromboembolism. You already know what is thrombosis. Next one is rupture. Rupture of heart muscle may occur in 5% of cases. Rupture occurs mostly on where infarction occurs because heart muscle is weak there. Next one is cardiac aneurysm. It also occurs in about 5% of cases. That is, there is a bulge or ballooning in muscle wall of the heart. Mostly it occurs in left ventricle, obviously, because MI occurs mostly in left ventricle. Next one is pericarditis. Pericarditis means inflammation of pericardium. So, but it is not infected, it is mostly sterile, and it is not serious, though it is common, but it is not serious. It resolves spontaneously after some days. Last complication is post myocardial infarction syndrome, which is also called as Dressler's syndrome, and it is characterized by pneumonitis. Its symptoms are mild, and it also disappears in few weeks, so not much clinically significant. So this was myocardial infarction, and myocardial infarction was third effect in effects of myocardial ischemia. So now fourth effect of myocardial ischemia, that is chronic ischemic heart disease. It is characterized by fibrosis in myocardium. You have already seen that after myocardial infarction, healing occurs, and healing by formation of fibrous scars. So that is called as fibrosis in myocardium. It may be focal or diffuse. Focal means which is focused on a single point, or diffuse which is spread in whole heart muscles. Now come to last effect of myocardial ischemia, that is sudden cardiac death. So what is sudden cardiac death? It means death within 24 hours of onset of cardiac symptoms. If a patient dies within 24 hours after his symptoms related to heart starts, then it is called as sudden cardiac death. And most commonly it is due to coronary atherosclerosis. There are other causes also, like coronary vasospasm, calcific aortic stenosis, myocarditis, hypertrophic cardiomyopathy, mitral valve prolapse, endocarditis, and hereditary and acquired defects also. So friends, this was the complete chapter of coronary atherosclerosis. I hope you have enjoyed it, and if you have any doubt or any clarification you need, you can ask in comment section. Thanks again.